Hello and good morning. I'm Kevin Rychik, a fourth-year medical student at the Sackler School of Medicine, and I'm pleased to present relationship between maximum voided volume obtained by bladder diary compared to contemporaneous uroflowmetry in men and women. Here are our conflicts of interest. I personally have none. Thank you to Dr. Blaivas and Dr. Weiss for the fantastic mentorship and guidance on this project. The 24-hour bladder diary is considered to be the gold standard for evaluating maximum voided volume. However, we observe that patients often have greater maximum voided volumes, or MVV, recorded in the office uroflowmetry than that seen in the 24-hour bladder diary. There are two non-invasive methods by which MVV can be determined: at the time of uroflowmetry, Q-MVV, or by a 24-hour bladder diary, BD-MVV. The purpose of this study is to compare Q-MVV to BD-MVV. This was an IRB-approved retrospective study of men and women evaluated for LUTS, a database of 771 patients evaluated for LUTS who completed a 24-hour bladder diary independently using a smartphone app was searched for inclusion into the study. We Share Uro is an electronic bladder diary software platform with a patient-centered mobile app. Exclusion criteria consisted of bladder diaries without a contemporaneous uroflowmetry within 3 months in the clinical setting, and those with incomplete or erroneous diary entries. Q-MVV and BD-MVV were extracted from uroflowmetry and the 24-hour bladder diary. When multiple uroflowmetries were available, the Q-MVV with the highest Qmax was used. When multiple bladder diaries were completed, the earliest one was used. For Q-MVV, the patient was instructed to wait to void until the bladder felt comfortably full to simulate a natural void. Sample means were compared, and Pearson's correlations were calculated across the total sample, women, and men. Now for our patient population. 771 patients with LUTS completed bladder diaries. Of these, 400 patients, including 205 women and 195 men, had contemporaneous Q-MVV. Here are the results of independent two-sample t-tests comparing mean BD-MVV to Q-MVV in the total sample and across women and men. For the combined group in the green box, the mean BD-MVV was 124 milliliters greater than Q-MVV. In women, in the red box, the BD-MVV was 104 milliliters greater than Q-MVV. And in men, in the blue box, the BD-MVV was 143 milliliters greater than Q-MVV. These three differences, when compared using t-tests to each other, were all significant with a p-value of less than 0.001. When comparing standard deviation, minimum and maximum values, we found relatively consistent numbers across the total sample, women, and men. A scatter plot depicts the relationship between BD-MVV and Q-MVV shown in Figure 1. Analysis of the relationship was performed using a Pearson's correlation. As you can see from the pink arrow, the Pearson's R is 0.34, indicating a weak positive correlation. When comparing BD-MVV to Q-MVV values, we calculated the differences between BD-MVV and Q-MVV as a percentage of the larger of the two measurements. In 165 patients, or 41% of the total sample, there was a difference in MVV of greater than or equal to 50% between the two measurements, and in 260 patients, or 65% of the sample, there was a difference greater than or equal to 25%. These differences are very significant from a clinical standpoint. Although the mean BD-MVV was significantly larger than Q-MVV and larger in 79% of the sample, the Q-MVV was larger in 21% of the sample. Moreover, when calculating the difference between the two measurement tools as a percentage of the larger of the two values, we found a discrepancy of 50% or more in 165 of the 400 patients in the sample. This suggests an estimation of MVV may be inaccurate by 50% or more if only one measurement tool is used. Furthermore, there was only a weak positive correlation between the two tools, with the Pearson's R of 0.34. These findings are significant because an assessment of patients' MVV through the singular use of BD-MVV or Q-MVV may be inaccurate. The primary weakness of the study is that it was retrospective. Additionally, uroflowmetry was performed as a routine procedure, not as a specifically targeted measurement of maximum voided volume. A third weakness is that the de-identified database did not allow correlation with Lutz questionnaires, clinical diagnoses, or medication. For a more reliable assessment of MVV, this study suggests that both Q-MVV and BD-MVV should be recorded, and that the larger of the two values is a more accurate assessment. Thank you for your time, and I look forward to answering any questions you may have.